So welcome to the second of our two-part Lunch and Learn series on the second substitute Senate Bill 5195 for behavioral health agencies. And today we'll be talking about clinical considerations specifically. Before we get started, I want to acknowledge that I'm speaking to you from Tacoma, the traditional and ancestral lands of the Puyallup tribe. Prior to colonization, this area was a vibrant community of Coast Salish people, including the Nisqually, Puyallup, and Saquon Island tribes. I recognize that the people and communities that lived on this land and cared for these lands since the beginning of time and continue to do so today. This land acknowledgement is one small step in true allyship, and I commit to uplifting the voices, experiences, and histories of the Indigenous people of this land and beyond. I honor and thank their ancestors and leaders who have been stewards of these lands and waters since time immemorial, and I commit to caring for the land, waters, plants, and animals. I encourage each person on this webinar to learn a little more about the Indigenous people who inhabited and cared for the land where you now reside. Thanks. This is a recorded webinar. I wanted to let everyone know that we will also give the recording. We'll share this afterwards and the PowerPoint slides as well. I've put in the chat the PowerPoint slides at the very top of the chat, so feel free to get those. And some quick housekeeping, everyone's muted. We ask you don't unmute yourself. Please enter questions into the chat box throughout the presentation today. We have folks monitoring that chat box, and then hopefully we'll also have time for open Q&A at the end. All right, so who's speaking to you today? My name is Laura Meter. I'm the Overdose Reversal Medication Program Director at the Washington State Healthcare Authority. I'm leading the Division of Behavioral Health and Recovery's workstream to implement and provide technical assistance and education on Senate Bill 5195, specifically to impacted behavioral health agencies and emergency departments across the state. I also am excited to introduce my collaborating community partner who you met last week as well. Mandy Slatke is an advanced practice nurse specialist in substance use disorders for Public Health Seattle and King County's overdose prevention and response team. She'll be taking on the majority of this today, and we're really excited to hear from her and her experience. Next slide. This is our agenda today. The session again is geared specifically for impacted behavioral health agencies. We won't be going into details on emergency departments here. And the majority of today will focus on aspects of clinical considerations when implementing this new law, including staff training and some case examples. And with that, I'll hand it over to you, Mandy.
Great, thank you so much, Laura. So hi, everybody. First, I want to jump in with a little bit of background and context for why this bill came to be, why it passed, and why it's important. So, and this is just, I'm going to go over this briefly. Some of you maybe saw this already in the first session, so apologies if it's a review for you. But drug overdoses here nationally and locally have been soaring in the past couple decades, with 100,000 people dying of overdose in a 12-month period this year. So as you can see in the graphs, the charts that I have down below, you can see that opioids and stimulants, which are shown on the right in purple, blue, and red, those are really driving these deaths. And the opioid fentanyl is causing especially dramatic increases in recent years, which you can see on the left in red. And I'm sorry, I think I meant the right on the other one. Anyway, you can see that dramatic increases in overdoses are occurring. In King County, largely that's from fentanyl, opioids in general, and methamphetamines. And we know that these deaths are preventable with harm reduction education, treatment access, and naloxone. But many of the people who are at risk of overdose death are not accessing these things. And we know that widespread dissemination of naloxone is safe and it saves lives. So the law mandates that people at risk not only get naloxone, but they also get information about harm reduction and treatment. Also, insurance is an already available and sustainable payment method. I know a lot of agencies are currently relying on grant-funded sources and like grant-funded sources from the state. And those funds could be used for other important initiatives. So the law requires that agencies bill insurance instead of using those sources whenever possible. So I know that a substantial amount of you are probably really familiar already with substance use disorders and opioids, but to make sure that we are all kind of on the same page. I know we have a really like mixed audience, people from different backgrounds working in different communities. So I want to make sure we have a baseline understanding and are all kind of speaking the same language in this webinar. So substance use disorder is a treatable medical condition. It involves complex interactions between the brain, genetics, environment, and individual life experiences. So basically what that means is for the genetics piece, some people are more susceptible and others are more protected kind of at baseline. And then we have those environmental experiences, those life experiences that play a huge role in whether somebody ends up developing a substance use disorder. So those are things like adverse childhood experiences, trauma, and social determinants of health. And although those things increase the risk, anyone can develop a substance use disorder. SUD is very common. Almost 15% of the US age 12 and up in 2020. That stat does exclude nicotine for some reason, although nicotine use disorder is certainly a substance use disorder. Symptoms of SUD include continued use despite negative consequences, intense cravings, and compulsive use and behaviors. So I want to point out here that we often blame people for chaotic and problematic behavior when they have a substance use disorder, when in fact these behaviors are often the symptoms of the disorder itself. So just want to think about stigma here. SUD is the most stigmatized health condition, and stigma is a huge driver of poor health outcomes. And there's a lot of research to support this. So if we use patient-centered care and treat all patients with dignity and respect, and we respect their autonomy, in addition to providing them with the tools they need to stay alive, like naloxone, harm reduction education, and harm reduction supplies, that can really improve patient health outcomes and ultimately save lives. So in order to comply with the law, staff need to be prepared. So we need to train in clinical best practices related to overdose prevention. So for staff training, we want to make sure staff are trained on overdose recognition and response so that they're familiar with what they're going to be educating patients on, and that they can respond to an overdose emergency in the behavioral health setting. We need to train them on identifying at-risk clients, providing client education on overdose recognition, response, and prevention, and adherence to clinical policies, procedures, and laws. So we're going to dive into each one of these and talk a little bit more about them. So identifying at-risk clients. So the law states that BHAs must provide harm reduction education to a patient with symptoms of OUD or reports recent use of opioids outside legal authority. So that applies to all of the patients that fall within these risk factors here. So any patient who uses opioids illicitly, I also add or other drugs, because we know that with the drug supply, sometimes fentanyl is ending up in other substances like meth or cocaine. So anybody who's using drugs illicitly should have a Narcan kit. Also, anybody who's in treatment for opioid use disorder, including those who are prescribed medications for opioid use disorder, meaning methadone and buprenorphine, there is a kind of misconception that people who are in treatment no longer need naloxone. We know that that's definitely not the case, because relapses happen. Somebody may be in recovery but still using occasionally, or they may combine their medication with other sedating substances. So there's still a risk there, even though our medications for opioid use disorder do significantly reduce risk. Also, anybody who's prescribed high dose or extended release opioids, anyone who has survived a prior overdose is at significantly increased risk of having a subsequent overdose. And then anyone who has reduced opioid tolerance. So if they're restarting opioids after a break or a change in the type or dose that they had been using prior. So this could be, maybe somebody was hospitalized for a while, or they were incarcerated for a while. That tolerance really diminishes very quickly, even within just a couple days. So when they resume use, they're at really high risk. And then anybody who uses opioids with other substances. So we often think about that being sedating substances like alcohol or benzodiazepines, but this is also true with meth. And we see this in the overdose death numbers a lot. Stimulants combined with opioids is very risky. And then I also want to point out too that anybody who is at risk of experiencing or witnessing an opioid overdose should have naloxone. So if you think about it in that way, it simplifies it. If you think somebody might have an overdose or see an overdose, make sure they get naloxone. So here's a helpful resource for identifying patients and helping to remember who should get naloxone. It's just a one-page printout that you can access at our website, kingcounty.gov/overdose. And it has prescribing guidelines for who should get naloxone. It has tips on patient education and counseling, some tips on safety planning and effective communication strategies. So I recommend printing this out, posting it around. It's useful for any staff who are dispensing naloxone or talking to clients about naloxone. So it's a helpful tool. So let's dive in a bit to kind of patient or client counseling regarding naloxone and substance use in general. So the most important thing that we can do in these interactions is to be non-judgmental about drug use. So we know that stigma makes people sick. There's a lot of research to support that. So if we're judging or shaming, we're harming. We don't want to harm our clients or harm our patients, of course. We instead want to instill trust and support healing. So we also want them to continue to access care, whether that means coming back to see us or accessing other kinds of healthcare, and that supportive and caring and non-judgmental interaction really opens the door for that therapeutic relationship and keeps people wanting to continue to access care. So we got to be non-judgmental. And then we also want to consider the barriers that they are experiencing and other things in their life that might be contributing to, their difficulty in making appointments or difficulty taking their medication regularly. Any of these things, patients are coming to us with a whole host of experiences and barriers. And we need to remind ourselves about that and understand where they're coming from. So when we're communicating with our clients, we want to encourage them to share what they already know. There are, a lot of conversations that we might have about their use and how to reduce their risk, how to use naloxone, but a lot of clients already have some information, and it helps build rapport if we're asking them what they know before we share what we know. So you might say something like, what do you already know about naloxone? And then we really want to be supportive of the steps that they're already taking to reduce their risks or improve their health. So if you have a client who has an alcohol use disorder, for example, and they recently cut back from, six drinks a night to 3 drinks a night, you want to be supportive of that, celebrate that, acknowledge that they care about their health. You can even say, you cut back on your drinking, you care about your health. And that can help open up conversations about other ways to continue to improve their health. We want to use open-ended questions to kind of just open the door for clients to get their needs met in the conversation, let them kind of lead the way. And then, of course, we want to avoid hurtful labels. So we want to use person-first language, and let's talk a little bit about that. Some of you may have seen some iteration of this before, but it's really important and something we need to continue to talk about. So as professionals, we really need to be using accurate and non-stigmatizing language in order to build rapport and build that therapeutic relationship and help patients access non-stigmatizing care. So terms to avoid, we really want to avoid addict, abuser, user, junkie. Instead, we're going to replace that with person-first language. So a person with a substance use disorder, or we can simply say patient or client. The idea behind this is that we don't want to label people based on their condition or what's going on for them. They are a person before they are anything else. And so things like addict is just really depersonalizing. And then abuser, like a substance abuser, has an added layer of implying violence. Somebody is not inherently violent simply because they use a substance. So similarly, we don't want to use drug abuse. Habit implies that their use is volitional or a choice. So instead, we can use words like drug use, prescription misuse, or problematic use. Certainly, people can use substances without it causing chaos in their lives. So just being more accurate about what we're actually talking about. And then when it comes to words like clean and dirty, like a clean urine or a dirty urine, we really can't talk about people as being clean or dirty. We wouldn't, for example, say that somebody with diabetes has dirty blood because their glucose is high. And so if we're acknowledging that substance use disorder is also a treatable medical condition, we have to talk about it like it is one and use accurate and non-stigmatizing language. And this is important not just as individuals, but also within our institutions, and our agencies can help promote this by setting an expectation for appropriate language, and then we can all respectfully hold each other accountable with this stuff as well. So we want to communicate risk factors to patients so that they're aware of the things that are risky. Risk factors for opioid overdose include that reduced tolerance, mixing opioids with other drugs. Again, this is not just other downers, but also stimulants. We want to talk about prescription pain medications, taking somebody else's pain medication. We know that a lot of pills purchased on the street are counterfeit, illicitly manufactured, and often contain fentanyl, so that's very risky. And similarly, any drug not obtained directly from a pharmacy or a dispensary is a risk for having fentanyl contaminated in it. Clients with chronic illnesses, especially heart, kidney, liver, or lung diseases, are at increased risk, and that's really because the body's just not able to cope with that overdose in the same way that somebody who has a healthy lungs or healthy liver can cope a little bit better, at least. And then, as I said, having had a previous overdose or using alone is also risky. So communicating those risk factors to patients. And then we want to talk to them about harm reduction measures. So the bill requires that agencies provide information about harm reduction strategies. And then also just the philosophy of harm reduction. For those of you who maybe aren't as familiar with harm reduction, the basic tenet is that it's interventions to reduce the negative effects of behaviors. And the philosophy is stemming from a respect for individual autonomy, knowing that people can make their own choices in life, and then a belief that everybody deserves to be healthy. So just because somebody engages in a specific behavior, like drug use, for example, does not mean that they deserve to be unhealthy. And then harm reduction also is a celebration of any positive change. So if somebody is, like the example that I gave earlier, somebody who has an alcohol use disorder, reducing their use, that is a really positive change in the right direction, and that should be celebrated and supported. And within that, the individual should really be deciding what positive change means, and that ties back into respecting individual autonomy. Some examples of harm reduction, just in general, are teaching safer drug or alcohol use, providing clean supplies. Even something like nicotine replacement therapy is a harm reduction measure. It's safer to use patches or gum than it is to smoke. And then we can broaden this out as well from a non-drug related example, things like birth control and condoms, seatbelts. Driving a car is one of the most dangerous things, or riding in a car is one of the most dangerous things that we all do on a very regular basis. And seatbelts reduce the harm of those dangers. So things that we know about harm reduction measures is that it does not enable or encourage or lead to increased drug use. So there's been ample research on this. Instead, harm reduction saves lives, and it makes both individuals and communities safer and healthier. So it does things like reduce the spread of infectious diseases, increase treatment initiation for substance use disorders. It increases community safety. So there's things like fewer improperly disposed of syringes. And then it also results in huge cost savings for healthcare and government. So there's less of a, for lack of a better word, less of a burden of disease for healthcare and government to be supporting and paying for. So here are some counseling tips for us to, things that we need to communicate to patients about harm reduction. And this is specific in terms of, it's specific to preventing overdose. So there are a lot more harm reduction tips about using more safely in regard to clean supplies and where to inject, where not to inject. But in terms of overdose prevention, we want to talk to clients about not using alone. So really try not to use alone because there's nobody there to help if you have an overdose or something goes wrong. If they must use alone, they can use a confidential service. So there's things like neverusealone.com and the Brave app. These things provide the individual with somebody to communicate with. And if they stop communicating, they'll send EMS to the site that the person indicated they were at. So so it kind of gets around that not using alone. They kind of have like a virtual person that's there with them to help. Alternatives also are to have somebody check on you often or use in a place where somebody is more likely to find you. Of course, it's better to just not use alone, but again, we're giving more information for people to make the healthiest choice that they can. We can counsel them to start with a small amount of the drug and increase slowly. So you can always use more. You can't use less. Once you've used it, it's already in the body. So we counsel people to use a small amount, see how it affects you. If you want to use a little more and you kind of have a sense of how it's affecting you, use a little bit more and just increase it really slowly. If you take it all at once, it's riskier. We also counsel people to take turns. So if you're using with other people, you watch and wait before the next person uses. You know, if everybody uses the same thing at the same time and they all overdose at the same time, they can't help each other. So by taking turns, we can ensure that there's somebody who is there to help if needed. We also want to counsel them to avoid mixing drugs. If they do mix drugs, which a lot of people, that's their method of, that's how they use. Lots of people use polysubstances, or lots of people are polysubstance using and prefer to use them at the same time. So if they do use, we encourage them to use one substance at a time and or use less of each drug than you would use if you use them separately. We also want to discuss fentanyl. So fentanyl can be in any drug, not from a pharmacy. And it is most often found in these blue M30 pills. So a small blue round pill with an M on one side, a 30 on the other side. On the street, they're commonly referred to as blues or perks 30s, and those almost always contain fentanyl. We also want to provide resources or refer if we don't have those resources on site. So we can refer to harm reduction programs like syringe exchange and to treatment if the client is interested and if they're not already engaged in treatment at your facility. So medications for opioid use disorder. The law also mandates that behavioral health agencies must provide information and resources about MOUD. So you get the patients in naloxone and then you ask them if they're interested in treatment and you provide them information with their treatment options if they are interested. So our gold standard of care for treating opioid use disorder is methadone and buprenorphine. They are safe and effective, and they reduce the risk of overdose death by over 50%. Very effective medications. So if you provide those medications on site, and the patient is interested, get them connected with that care, or you can refer. And some resources for doing that are the Washington Recovery Helpline. And then just to learn more about these medications, if it's not already a part of your practice, you can check out learnabouttreatment.org. And then there's also the Healthcare Authority informational sites that Laura has shared or will share. And so just some resources for you if it's helpful for your practice. I've linked to a harm reduction safety plan and an early recovery plan. These can be a useful tool to have these conversations with patients and kind of have them be guided. The harm reduction plan includes those overdose prevention strategies, and then it also has a space for clients to write maybe some like additional ways that they plan to reduce their risk, and kind of get them thinking about how they can improve their health and choose less risky behaviors if they can. Then the early recovery safety plan has space for clients to write things like why they choose to be sober today and what helps them remain sober, places to identify triggers, places and things they can do or people to call if they are experiencing triggers and cravings. So those can be useful tools to guide those conversations. So I want to hand it over to Laura to go through some case examples and kind of put what we've talked about into practice a little bit.
Thanks, Mandy. Great job. Yeah, so I have two case examples here. You can advance the slide. We'll talk about the first one. Let's see, I think, yeah, there we go. All right, so I'll read this out loud. I know you all can see the screen, but just to go through it. A 45-year-old male who is stable on buprenorphine for over 5 years presents for behavioral health care to address recent mood concerns, so low mood and situational anxiety. And the client gets buprenorphine prescribed through his primary care provider. A remote history of daily heroin use, and that was over 5 years ago, that history. Takes his wife's lorazepam PRN for anxiety at times, and also has a couple drinks or so a few nights a week to unwind after work. So just before we move on from this, and I know Mandy mentioned it, but buprenorphine, sometimes referred to by the brand name formulation Suboxone, is a medication to treat opioid use disorder in this case example. All right, next slide. So case one considerations, the focus of treatment here is anxiety or mood concerns, as he's mentioned. However, just to sort of make clear, like he meets criteria per the law to be asked and offered prepackaged naloxone. The indicator here is that he has that he's on buprenorphine, which again is the medication for opioid use disorder. So as a note, when discussing naloxone with patients, in this case example, he may not consider himself at risk of overdose. He's in long-term recovery, is feeling stable, not using opioids. It can be useful to frame this conversation and naloxone itself as being given just in case, or if to be used on someone else if he's not relating to an overdose risk. Also, it may be useful to highlight overdose risks if it's appropriate, of mixing sedating substances. So in this case example, alcohol, the couple drinks he has a week, and or taking his wife's benzodiazepines to alleviate some symptoms of anxiety, and mixing those with buprenorphine, which, while is a medication for opioid use disorder, is a partial agonist and also occupies the receptor, and then therefore the combination can be more risky for possible overdose. If appropriate, you can also complete a safety plan or explore alternatives to anxiety management. As you mentioned, I know once we send this out, you all will see the links there. So if those are appropriate for your setting, that would be good to do. Under 5195, I want to make a note with this case example that your organization, even if somebody is there specifically for mental health treatment alone, is still required to do the basic screening and provide the naloxone in hand if the client meets criteria. So in this case, if asking him, you'd still be required to ask him if he has naloxone, and if not, help facilitate getting that kit in hand. And even though he's getting SUD treatment or his medications for opioid use disorder through a different provider, in this case, his primary care provider is prescribing the buprenorphine, it's still incumbent on your organization to do the screening and getting those in hand. So just want to put that out there. We can talk about that more as well. And then, but to be clear, your role is simply to assess and connect someone who's at risk with a kit in hand and the required education. If the scope of your work is really mental health treatment, you do not need to start, and it's called out specifically in the law, you do not need to widen that scope to facilitating evaluation or SUD protocols, anything like that. It's simply to assess the need for naloxone and then get the person the naloxone. All right, next case. I'll start reading it here. So case number 2 is 25-year-old who's unstably housed on the streets, presents for behavioral health care and housing resources. On intake, he reports IV use of methamphetamine approximately 3 times a week with clean supplies, and reports smoking Perk 30s or the fentanyl pills, which knowingly contain fentanyl on a daily basis. He's not currently interested in making changes to his use or engaging in formal SUD treatment, but would like his abscesses drained. Reports that he used to have a naloxone kit, but isn't sure where it is, and verbalized that he's not worried about overdosing. He's been fine using this way for the last year. All right, next slide. So first things first here, again, he meets criteria to be offered, assessed clearly, and then offered the prepackaged naloxone kit, which is what the foundation of this law is, 5195. We covered a lot of that also last week in the implementation piece. So first thing first, you'd want to see, if he doesn't have a kit, we'd want to offer him another one and the education potentially, or the education that goes along with it. It may be helpful in this case to highlight the positive steps he's already taking. So saying something like, you're using clean supplies, you care about your health. This is what Mandy covered a little bit earlier, some motivational interviewing around that, or really just reinforcing any positive change that the client's participating in around his health. So just to note, this person in this case example is aware that fentanyl is in the drugs that he's using. A lot of times we talk about the risks of fentanyl being in things and people not knowing that it's in there. In this case, and in a lot of cases, people are aware that there is fentanyl and they may even prefer to use it. He may or may not be aware of its potency and also that the amount of fentanyl in each pill he's smoking isn't consistent necessarily, right? So there could be one pill one day has a lot more and could cause a potential risk for overdose. So this is a great opportunity in this case example, if the client is open to engaging about it, to talk about safer use, setting safer conditions, and potentially with permission, psychoed about overdose. And you can use the HCA resources, which I'll show in just a second, about strategies and services, and basically how to respond to an overdose as well, how to identify it. And you can utilize these educational materials in sort of your conversations with clients. Finally, as appropriate, in this last part, connect, refer to services and community resources like housing. This person may already be familiar, for example, with syringe service programs or SSPs, as he's noted that he's utilizing clean injection supplies. But SSPs are a tremendous resource. These programs help people who use drugs to stay healthy, and they provide clean syringes, injection equipment, syringe disposal, naloxone as well, and access to healthcare, including wound care and buprenorphine at some sites. So he may be able to get his abscess drained at an SSP, for example, in this case, if your organization cannot or it's not appropriate to replace or to place a referral for wound care. And then, of course, connecting him to housing or any other requests. So this case really also stands to highlight the ability to meet somebody where they're at and address their goals and needs. For him, it's housing and wound care. And naloxone's a direct way to help facilitate that conversation and give someone in hand a life-saving tool and resource. So on to the resources. I sent out an email that many of you who are registered for this and the previous last week's webinar hopefully got, that HCA now has client education brochures, which the law outlines should be given to folks who receive the prepackaged naloxone under 5195. These materials are in English right now on the webpage, but they will be translated by the end of the year into multiple languages for different communities. And there is the webpage for HCA's linked there below. I do want to note that our communications team had to make some quick updates to the webpage, and the educational material links are now back online. When you do go back onto the webpage, if you've been there before, make sure to clear your cookies so that you can get into those links properly. Again, sorry for the inconvenience. We had a day where it was down, and that was an issue. So I posted them as well as this at the very top of this chat. So you should also be able to pull the PDFs of this document and then the next one if you want to advance. This is to the harm reduction and medications for opioid use disorder. And then, like I said, you can use these tools as actually like teaching tools, and we will be providing in the forthcoming Behavioral Health Agency Toolkit guidance on how to train staff and how staff can use these documents as well. Oh, I just see something in the chat from Zoe. Thank you that there's nothing there if you've joined after. I will make sure everybody on this presentation gets a copy of this slides as well as these the PDFs of the
Laura,
education. Yeah.
There's also some questions in the chat about implementation. So I wanted to give you the opportunity to kind of plug our previous session that might be helpful.
Oh, sure. I missed those questions, but if there are and we'll open it up here because we're almost through this presentation, so there'll be some time. But I think to your point, Mandy, last week was really very focused on the implementation side of 5195, which I know there are still a lot of outstanding questions and thoughts on that. I will make sure when I send out this information to also highlight our webpage where you can go and see the slide deck from last week and also the recording if you missed that. Is that sort of addressing that, Mandy, sort of the resources there? Okay. And then, so yeah, this is a preview right here of the HCA client brochures that we just mentioned. And then if you'll advance to the next, we covered these last week, but feel free, of course, to access or reference additional great resources from our partners across the state who are doing wonderful work. And then as you build out this program, you can definitely use any and all of these resources and the resources on the next page here. So next slide should show just some of the legal resources, additional MOUD resources. And then, yep, you're good. You can go to the Washington Recovery. And then wanted to briefly call out, I know Mandy mentioned it earlier about accessing the Washington Recovery Helpline. This is a central resource that you can provide your clients on connecting to treatment or other services like SUD peers, and again, medications for opioid use disorders. They have a great locator on their website that you can actually sort of filter down where to find MOUD and other resources. And then if you want additional marketing materials for your agency, please go to their website and you can request these. Maybe easy to just hand a card out or have these posted as a way to encourage people to really access treatment or other resources as needed. And then finally, let's move into question and answer. I'm sure there's a lot going on in the chat right now. I have a colleague as well on here monitoring that. Were there some themes that are important before we open up just to for people to unmute themselves and ask questions, Liz?
Yeah, there's definitely some stuff that is covered by our conversation last week. So I'll make sure to post the link to that webinar and kind of those materials in the chat. Regarding new topics, I think that there's definitely a couple questions about when would naloxone need to be provided in hand versus, kind of assisting someone in obtaining it. How would you distinguish between the two, and how far does someone need to go in order to assist?
Okay, happy to answer that. So the law says as soon as reasonably possible. So that means ideally, in an ideal world, if somebody is assessed that they are appropriate to get, at risk of overdose or meet the criteria, that we would be able to facilitate that as quickly as possible. As covered last week, I would encourage, if you have a lot of questions around that piece, to to review last week's implementation, but because there's different channels for behavioral health agencies to facilitate the distribution or dispensing of naloxone. So depending on your agency and what you've decided will work for you, whether you're using on-site pharmacy or pharmacy partnership in the community or mail order, that will determine how quickly that naloxone kit will get in the hands of the person who you've assessed at risk. Hopefully that helps with that question. But again, I will also put my information here. It's all over the website and some of these, but if there are specific situations where you'd like to talk through some of these things, have questions, or would like to request additional training for your staff, I'm happy to just please reach out to me and we can coordinate something. I'll put my email in the chat. Anything else, Liz, theme-wise before we'd open that up?
Yeah, can you talk a little bit about the implementation or coordination for folks who are living in adult family homes, skilled nursing facilities, things like that, and how to ensure caregiver or facility participation in the program?
Oh, okay. So in that case, it's really through, so if people are living in, let's say, an adult family home and they're attending a behavioral health appointment, and through the protocols you've developed for screening and assessment, they screen in, meaning that signs and symptoms of opioid use disorder or reported use of opioids outside of legal authority, then you can facilitate like anyone. I believe you would want to work with the adult family home on if you're not able to give the kit in hand, and let's say you're using a mail order pharmacy, you'll want to coordinate with them if all medications have to be cleared through the adult family home. So there might be some complexities there, but there's all the information as far as the resources for education should be given to, will be public and made available, like given to the client, but also encouraging them to have those conversations with people in their support network. So feeling empowered for them to understand how to administer naloxone, of course, and if they're the ones experiencing an overdose, they need to also have that awareness brought to the people that might be around them. So either carrying the sheet or sharing it with the adult family home, or their own network of folks that would be potentially there witnessing the overdose. But that's a really great call out as far as pharmacy specifications around certain, like for adult family homes. I know there's challenges around discharging with medications, et cetera. So I can also make a note and follow up on that. We will have a frequently asked questions for both behavioral health agencies and emergency departments coming up, and these webinars have been critical in developing themes to figure out like what we should be answering in those cases. So keep those coming and those questions. Anything else, or do you want to open it up to folks?
Go ahead and open it up, and I'll keep scanning through to see if I can find any trends.
Okay, great. So if you do have a question, just raise your hand, and then we'll just call on you, or you can unmute yourself. I just didn't want a million at one time. And if not, I'll be looking here to see some of the questions that are in the chat. I see
Laura.
something. Oh, go ahead.
Oh, Laura, my question was regarding the AFHs and the EFSFs. Would it be possible for the adult family home to have the naloxone on hand, but then also have an order for the patient? Because they may have an overdose at the facility, but there's also a possibility that they may be out in the community.
Right. So that's a great question. There's, through the statewide standing order, any organization or individual can utilize that standing order as a prescription, basically, without having to get, and that's part of how we're actually, like some of the processes for getting this law up and going is the fact that we have the statewide standing order. So the actual adult family homes, of course, just as a measure of like first aid almost, it would be important to have it on hand, and they're able to obtain it. Any organization is. Now, So, and then as far as being out in the community, I would say that if the behavioral health agency who is potentially meeting with this individual who lives in the adult family home, that they would want to encourage them to carry the naloxone and the instructions for use and have that on their person, with an understanding of how to administer and talk about that. And then I think it's a great conversation to have at adult family homes from an administrative perspective to keep that on hand too and have staff trained.
Okay, thank you. So the staff can get their own prescription for it. They're the
Yeah.
adult family home, which would be separate than the patients. Thank you.
Right.
That's
Yeah,
helpful.
utilizing the statewide standing order. Mhm.
Looks like Caitlin has her hand up.
Oh, all right. Hi, Caitlin.
Hi, good afternoon. Thank you for putting this presentation on. I think it's been really helpful for some of us trying to navigate this. My question is, we are an outpatient, more like, therapy session kind of facility. And judging from the call last week, we kind of thought that it would be all right to send patients down to the pharmacy to refill or to get their naloxone. One of the thoughts that I had was, if we do that, then who is responsible for educating the patient on how to use the naloxone or whatever it is that we are going to prescribe for them? We would obviously have the education materials, for them in the kit. The only thing that would be missing would be the naloxone. But I think that in our organization, we just kind of wanted to get some clarification on who would be responsible.
So if your organization meets the criteria as an impacted behavioral health agency as covered last week and in the RCW, you unfortunately cannot just give them a prescription to fill down at the pharmacy. You will have to facilitate, so that that can look like a couple different things. It could look like a staff member getting that prescription with them filled, but the prescription alone, unfortunately, will not meet the standard of 5195. So part of it is whoever is tasked in your procedure or protocol development with assessing. So if it's at the time of intake, treatment planning, or discharge, or more frequently than that, which is how it's outlined in the law, then they will likely be, you can do it in a lot of different ways, but if that's a case manager or a therapist, let's say, that individual would then be charged with making sure that the patient got the education materials. So part of this is developing a protocol or a process and a policy that incorporates those elements, and then making sure that they get the kit in hand, or utilizing their mail order so that it goes directly to the patient. But the disconnect is that if you have on-site pharmacy, which would be helpful, then coordinating with on-site pharmacy to actually get the kit up to them and making sure that they actually get it versus a paper or electronic prescription. Does that make sense?
Yeah, it does. And I think that I can see the questions in the chat going, and we're all thinking the same thing, because without the bulk prescription, feature, then you're basically making it sound like we have to keep it on hand at the clinics, and how to go about doing that. And billing, from last week's call, billing isn't really up and running yet. So how are we supposed to get the gears moving? Essentially is what I'm trying to figure out now.
Okay, great questions. And I don't want to backtrack too much on that. I want to make sure, would it be all right if they're to sort of connect offline and specifically troubleshoot potentially some of this for your organization? Or if I'm not able to really read the chat as I'm talking, but if this is thematic, sort of maybe what would be beneficial is to review, for me to review or make clearer ways to help on the implementation side. I'm happy to do either, but I also do want to highlight that it's there, and you'll see it in last week's implementation slide. The law does call out that you can use any state approved, I believe it says, means of obtaining naloxone. So if this is not feasible for you to be working with the pharmacy on site, or you're having troubles with a pharmacy like partnership in the community, there are other resources. So there are currently and temporarily organizations can utilize grant funded naloxone. However, there's limitations on that, and there may or may not be enough to go around with that. That's not sustainable, but the law does call out that that can be used until the bulk purchasing program is up and running. So if there is something that would be useful for you to check in with there, I'm happy to talk about that as well. I see a hand up from Tammy Baker.
Yeah, I think if you're going to have that offline conversation, there might be a lot of behavioral health only agencies that would benefit from that, because from what I'm hearing is if we don't have an on-site pharmacy, we've got to actually walk the client to the pharmacy and assist them in getting it. I think there's going to be some barriers to that. And I think maybe if you're going to do a set aside meeting, it would be helpful to put an invitation out to other people that might find that discussion beneficial. I'm assuming though, if we do have an on-site pharmacy and we walk the person up to the pharmacy or over to the pharmacy, wherever it might be located, then that would meet the, after obviously we've done the risk assessment and provided the education, but we could walk the person to the pharmacy could give the person the kit and do the education piece potentially, and that would meet the requirements, correct?
Right, yes. And I think there would be like, this is what I'm imagining as a workflow, but if in this identification at any one of those 3 or other clinical opportunities, your organization says, oh, okay, based on these criteria that we know, you may be at higher risk for opioid overdose. As a result, I want to, do you have naloxone? No. Okay, would you let me tell you about naloxone, and also we can get you a kit? Then that may be the area where you can take those, the flyers, and you can have the education piece in one. So it's not meant to be a 45-minute interaction. It's meant to be the information that you need will be on these or are on these brochures, and you can teach to those very quickly, and then kind of move through the workflow. But yes, and of course, I was not meaning to just say like I'll back channel only with you. I think it's great to highlight, and I appreciate you highlighting that this is an area where people want additional support. And then going into the new year as well, I'll be hopefully having more technical assistance sort of meetings and topics like this. And so the more you guys can share about what would be helpful, the better. Thanks, Tammy. Is there any other hands up, or Liz, any themes you'd like to pull out from the chat?
Veronica has her hand up.
Okay.
Hi, Laura. Thank you. We're kind of in the same boat with Tammy in terms of needing technical assistance. We predominantly serve youth in the schools. Is there a requirement for the schools to have this on stock, or our services are community based, but we don't necessarily drive clients to locations. We meet them at locations, but a huge percentage of that is in the schools. So if I'm understanding correctly, and the bulk distribution is no longer available, I'm just trying to understand on the implementation side, how do we help our youth participants who might need this get access if we're meeting them in the schools? Yeah.
Yeah, that's a great question, especially very setting specific. And just to clarify, the bulk purchasing and distribution program, which is talked about in the law and was referenced last week, is a work stream that's underway, but it's the long-term solution sort of to this, whereby HCA, once this is developed and up and running, will have a mechanism to purchase and of course distribute naloxone to help facilitate 5195. But that's sort of, right now we're talking more about the interim solutions before that comes into play. Schools themselves are not part of 5195, the purview of that. So that setting themselves, the schools are not required to participate in this. As a behavioral health agency going out and other people who are doing like street outreach and meet these criteria, yeah, those are considerations that are very setting specific and on the spot. I think that's something that I probably would want to think a little bit more about and understand how to maybe give some technical assistance and guidance on how to best meet those needs, especially for the youth you're serving. So I'm writing it down. And that will be another area to follow up on for the frequently asked questions. But thank you for bringing that up and asking about that. And hopefully the bulk purchasing clarification made sense. If not, reach out.
Yeah, thank you so much.
I had a question for you. Just in follow-up to the question I asked you in our last session regarding storing Narcan at, a outpatient level with a standing order that has instructions, that's included, and then documenting it, inventory, and then handing it out under those circumstances. I had asked something about, what the difference was with the standing order from the state versus if we have it ourselves, and if we could store the medication at outpatient level.
Can you clarify just
For
that
non-medical units.
last part about have it yourself versus the standing order? I guess just so I understand.
Oh, sure. So there's a state standing order that has been offered, but then also individuals can obtain a standing order through their, medical director of their organization, for example. I was wondering if it makes a difference to the storage of the, there's a grant specifically that says that you can store Narcan at your facility under a specific standing order, I believe the state one, but I'm trying to get clarification on the difference between whether it's the state standing order or your own medical director's or standing order, and then also clarification on if there's going to be some changes in the criteria for, because it could be almost considered over the counter, because of the standing order. If you store it at your outpatient program and have an inventory, of it, if that's something that you will be seeing, individuals pursuing it that way rather than a pharmacy.
Gotcha. Okay. Yeah. So I got clarification about the statewide standing order, and if pharmacies, if we're utilizing that, it's basically a prescription, right? So that is the same thing. It doesn't necessarily make it doesn't make any drug over the counter. It's just in lieu of a prescription that it's being used. So as it relates to storage, I have also seen that RCW, which now, of course, I'm not remembering the number, but which it does allow under that statewide standing order, the storage of it. And I would imagine, but I can get follow-up and clarification for you, Marcy, if that's any different than the standing order that a medical director or provider for an organization, if the storage is impacted any differently. I believe it's speaking overall to overdose reversal medication, but that clarification I can follow up on and make sure people know.
Okay, so I'm going to look into the RCW as well, just for the details, and but it does look like potentially we may be able to store, Narcan at, in a non-medical setting,
right,
with a standing order and with instructions included, and just dispense it to clients. Obviously they're going to self-administer with somebody that they're with outside of your facility, so we're not actually dosing them, but giving it to them on site so they can leave with that and have those instructions handy for themselves.
Yeah. Okay. The great question. And I think that we'll just clarify sort of some of those, cross those T's and I's, like dot those I's about the difference if there is any. And
okay.
I'll
Thank
follow
you.
up. Thanks. I know it's just 1 minute till. Is there any sort of final theme to address, Liz, in the chat? If we haven't gotten to your question, I have a copy of the chat and will have been going through and making these themed questions and following up with answers, and we'll be getting those out.
I think that there's quite a few questions about the ability to bill for the time the agency spends implementing the program, assessment and screening of the patients and that kind of thing.
Okay, great questions. Probably at the top of the hour, one that I will not be able to dive deeply into. What I can say overall is that the bill does not outline a separate billing code to implement this law. It's unfortunately something that is just become effective in in the next couple of weeks, and I really believe, and I said it last week, that all behavioral health agencies have been outstanding and super resilient and flexible in these crazy times. And this is one of those things that I know you all will do really well, even if it's a huge lift, but we're here to help and we're here to make this as answer those questions and do what we can to help your organizations. So with that, I will make sure to follow up on the questions that are in the chat log. Appreciate all of your candid feedback and want to thank you for your time and attention to this. And please reach out with more questions or any clarification. And thank you, Mandy, for your time in presenting today too. And with that, I will talk to you all soon. Thanks.